be of 46XX or 46XY, or it could be a mosaicism, or mixed gonadal dysgenesis, or abnormal X chromosome. This is the Turner syndrome. Turner syndrome, this picture shows it clearly. Sexual infantilism, short stature, webbed neck, wide space nipple, cubitus valgus, shield chest, or pigmented nevi. The main thing is the coarctation aorta, which is a life-threatening condition, or renal anomalies, or strict gonads. Turner syndrome could be of different types. It is 45X0 or 46X0 or XX mosaicism, or 46XX, but the short arm of the X chromosome, another second X chromosome will be deleted, or it could be a reversal. Now, primary amenorrhea with breast development and lack of pubic hair and axillary hair. This is a fourth entity, is known as testicular feminization syndrome or complete androgen insensitivity. The genotype here is the 46XY male, and intra-abdominal or intra-inguinal testes will be there. And phenotype is a complete female, and as 46XY is present, SRY gene will be there, which will be responsible for secretion of Mullerian inhibiting hormone, which will inhibit the development of uterus or vagina. And gonadectomy is required in this condition because after puberty, the gonads will undergo neoplastic degeneration. So for that, we can keep the gonads up to puberty, and after puberty, gonadectomy has to be performed. Now, this individual is brought up as female, so psychological counseling is required before marriage. She cannot have babies like that. Now, primary amenorrhea with normal secondary sexual characteristics. Normal gonadal secretion, vast majority of X, 46XX, amenorrhea due to anatomical abnormalities. In case of absent vagina or uterus, creation of neovagina is the answer, either by dilators or by vaginoplasty. With uterine or vaginal abnormalities, always we have to think of renal abnormalities. So, if the uterus is not present, it is the MRKH or XY female, or known as Morris syndrome. Or if the uterus is present, then it could be due to imperforate hymen or transverse vaginal septum, or hypoplasia of the uterus, or the endometrial lining is affected by any infection like tuberculosis in our country, or systemic illnesses, maybe systemic tuberculosis, or maybe malnutrition, or it could be a constitutional delay. We can blame at the last. Now coming to the Morris syndrome. Morris syndrome is the male karyotype and female phenotype. Male level of testosterone could be found here, and it is a receptor failure and 5-alpha reductase deficiency. This is the comparison between the Mullerian agenesis and the Morris syndrome. In Mullerian agenesis, it is a female, 46XX, and Morris syndrome is 46XY. So androgen level will be higher, means the testosterone level will be higher in Morris syndrome, and testosterone level in Mullerian agenesis will be female range. Mullerian agenesis is sporadic mainly, but Morris syndrome is X-linked recessive, and sexual hair is a female distribution, and XY female is hairless. And anomalies are more associated with the Mullerian agenesis, and for Morris syndrome it is rare. And tumors are not seen in Mullerian agenesis, but neoplastic changes can occur with Morris syndrome. Now, this upper picture here, it is normal cut section, and here it is for the Turner syndrome. And this is the picture of introitus, and this is the picture of imperforate hymen showing the hematocolpos. Now, evaluation for the primary amenorrhea. History plays a very important role to diagnose the primary amenorrhea. We have to take the personal history, family history, or past history. Whether the patient is affected, whether the patient is undergoing any psychological stress, or whether she is doing excessive exercise, these histories we have to take, or any individual in our family or any siblings are affected or not, we have to check for that. On physical examination, first we have to look for the secondary sexual characteristics, and virilizing manifestation also has to be noted because to exclude the diagnosis of any androgen secreting tumor. And weight, height we have to note according to time. And sonography plays a very important role to visualize the internal structure without any invasion. And laparoscopy could be done. This is the invasive procedure. Gonadal biopsy could be done to confirm the diagnosis. Now, investigation, buccal smear to detect the bar bodies from the oral epithelial cells, and karyotyping could be done to confirm the diagnosis whether she is 46XX or 46XY. And endocrinological evaluation, FSH, LH level, those are mandatory: prolactin, TSH, estrogen, and androgen level. Now, management of the primary amenorrhea, the aim of the treatment is to attain the maximum physiologic function. No treatment should be done until the diagnosis is confirmed. The majority will be able to achieve satisfactory sexual life, but the prospect of fertility is very poor. HRT may be required for the later life. Now coming to the Mayer-Rokitansky-Kuster-Hauser syndrome. This is also known as MRK syndrome or Rokitansky syndrome, Mullerian agenesis, Mullerian aplasia,